Hi everyone, thank you for joining this webinar on managing entry and release from prison. We've got a really great panel of speakers for you today. My name is Megan Georgia and I'm the Programme Manager for the Quality Network for Prison Mental Health Services. And this session is co-hosted with the Royal College of GPs, Secure Environments Group and SMMGP. And our speakers today are Dr. Caroline Watson, Lead General Practitioner from HMP Bedford, which is part of Northamptonshire Healthcare, and RCGP Clinical Champion Healthcare and Secure Environments. We also have Dr. Stephen Attard, Consultant Forensic Psychiatrist from HMP Woodhill from CNWL. Dr. Jake Hard, Chair of the RCGP Secure Environments Group, Clinical Lead for HJIS and Medical Director for Prisons for CRG Medical Services. And finally, Dr. Anna Hiley, GP with special interest in substance misuse and offender health, and CEO for Inclusion Healthcare and SMMGP representative. So as usual, any questions that you have, please use the Q&A function and the speakers will answer these as we go through. And we will be sharing the recording after the event and putting it on our website as well, so you can share that with any colleagues that may have missed today's session. And we hope you enjoy it. So I'll now pass it over to Caroline for you. Caroline, you should now be live.
Thank you. Thank you very much, and thank you very much for coming onto this webinar. Can we go on to the first slide, please, Megan? Thank you. So I really wanted to just have a few minutes to look practically at thinking about the risks and how we manage those for people coming into prison, particularly those risks that have been come about because of COVID. I think that anybody who's working in a reception prison will have perhaps come across, as I have over the recent weeks, the fact that we are seeing a number of patients coming in who have not been having the same level of face-to-face contact in the community, and particularly with community drug services, and also the fact that there is more unsupervised consumption and larger amounts of opiate substitute treatment being taken away from chemists. So when we are seeing people in reception, we're often seeing people who've had perhaps a 14-day script or a 7-day script that they've had at home. They may come in, they may have been on, for example, 70 mils of methadone, and we're not sure. We're not sure whether they have been taking that regularly, and many of them may have been, but we do not know whether some of that has been sold, some of that's been taken, and there is therefore that risk, that the difficulty of balancing whether to have somebody who could be withdrawing and feeling very uncomfortable, but also then the opposite, if we give somebody the medication that they've been prescribed but may not have been taking, we could risk overdose and death. So part of the information from NHS England Health and Justice team has been to proceed with caution, to be really looking to consider an induction course if that is necessary, and using the observations that we would normally do in those early days and changing the dose according to those observations. So safety versus continuity, there has been a really helpful information increase that has come in through the summary care records. There's additional information that is now available in reception that we are now able to see, often more than just prescriptions that people have been written, but also some of their problems and the summary read codes. So that's very helpful, and Jake may be able to describe a little bit more of that later on. As to how much to prescribe and whether to prescribe it in possession or not, we are being encouraged during the COVID pandemic to have as much of the medication prescribed 28 days in possession, and that includes 28 days not in possession, but of 28 days scripts of OST that would be supervised consumption where there is available staffing. Where we are doing the in possession template, the in possession screening as part of the first night assessment, that is a helpful pointer. If we are dealing with somebody who's been transferred either from another prison, having just had an act closed, or if they aren't suitable for an in possession, then clearly we will need to make sure they have supervised consumption until it's safe to do otherwise. As for when, after an act closure, is it suitable for in possession, I should imagine Stephen would have some very helpful advice, but certainly from where I work, we have taken multidisciplinary decisions. So we will be looking at the reasons for the act, we will be looking at the duration from the time of closure, and that would inform our risk. And Megan, could I have the next slide, please? Thank you. Thank you. So as well as what we need to find out, I think it can be helpful to give patients, residents coming in through reception information. And there are, I'm sure, individual organisations have got some excellent resources. For those who don't and who would like some, there are some useful resources on the Royal College of GP's Secure Environments. It's in the COVID resources and in the Secure Environments section. So there is a simple question and answer, frequently asked questions patient guide about how to keep yourself safe from coronavirus, and also just literally launched yesterday and in the process of being disseminated through Prison, NHS England and chaplaincy routes. There is a new resource which is picture-based, which is designed principally for people who have lower levels of literacy or who don't speak English as their first language or who have learning disabilities, but actually can be a really useful resource for healthcare teams, for officers, for peer mentors in trying to have conversations about what the differences are in prison during the coronavirus. So there is a link there, and this PowerPoint will be up on the website afterwards, won't it, Megan? Can I have the next slide, please? So I don't know about you, but it's been a journey and a half getting to grips with risk stratification. And it may be that in your prison that you're working in, you have got a really slick, smooth system. We are just getting ours under our belt, and who does what when will be a local choice. But I think where we were coming to terms with it a month ago, having high-risk patients and then clinically extremely vulnerable ones, and the high-risk patients were being advised to have stringent social distancing, and those clinically extremely vulnerable were being advised to shield. Now we have a new classification. It's relatively new anyway. So we've got the clinically vulnerable group, used to be the high-risk group. It used to be the group who was advised to have stringent social distancing. That, if you read code it on TPP on System 1, you will find that it comes under moderate risk. So clinically vulnerable patients are classified as moderate risk, and there is a read code which is Y228B. Those people who are clinically extremely vulnerable are the ones who were at highest risk before, and they are called high risk as far as TPP risk classification goes. And those are the ones who will be advised to shield. And that's, if you, I'm sure you may be aware of it, but that's Y228A. All of those other people who don't fall into either the moderate or the high risk categories will be in the low risk, and there is another read code for that. Now, I know it's a quaffable thing, and I know that we aren't necessarily looking at that, but I know that HMIP are also doing COVID spotting inspections, and so I think it's useful that this risk classification for the benefit of the patients can be done as soon as possible. Perhaps the first night is a possibility if you've got a good access to the SCRA. Otherwise, it may be done at secondary screening. I think it will depend on the number of people coming through the doors of your prison on any daily basis. It may just simply be too busy in reception. But it certainly is important to do it while you have people in their reverse cohorting period in those first 14 days, so that you're able to not only protect them from any potential infection in the prison, but you're able to identify who will need shielding once they're out of the reverse cohort unit. Also, obviously, if you're identifying those who are clinically vulnerable and extremely vulnerable, those are the people who will need your long-term condition management. And as the crisis, the immediate crisis of the first wave has finished, we are now being encouraged to make sure that we are not neglecting those long-term conditions. So very briefly, on reverse cohorting units, you may well be all familiar with this, but it's for 14 days when somebody either first comes into prison, if they're being transferred from another prison, if they have been going in and out of court to a court case, which is beginning to happen now, my understanding is the case. They will need, if somebody's going in on a daily basis to court, they would need to be in a reverse cohort process, and they would need to do that for the duration of the court case and for 14 days after finishing. The other group of people who need to be in the reverse cohort unit would be those who have just come back from hospital, unless it is a day visit and they have managed to keep good social distancing. So reverse cohort, it ideally may be one area in your prison, and it ideally would be away from the other areas. However, as we are all experiencing, that is not always technically possible, and what we do need to make sure we're doing is those people who cannot be put in a specific area can at least be part of a reverse cohort process, so they can have a reverse cohort regime that is separate from the other residents on that unit or that wing. So then for those who are shielding, the big question we're all waiting to find out is exactly when shielding will be relaxed and what that will look, because we know that in prisons it may happen later than in the general population. We also know that if there is a local outbreak, then the shielding will need to, those restrictions will need to tighten. But for now, things continue as they have been for the past number of weeks. I know in the community now, shielders are allowed outside. They're ideally for just once a day, and they still have to socially distance and only meet for one. Now, in reality, my understanding is that because most prisons are closed units and we have got a finite headroom, people have been going out, and there is a requirement for 30 minutes of exercise and fresh air in the day. People have been going out already. So practically speaking, although there's been a change in the community guidance, I don't think we are seeing that as yet. There's no change to what we are looking at in the prison side of things. Finally, the protective isolation unit, again, this is 7 days or minimum of 7 days if somebody is symptomatic. As for if they are tested, that will be dependent. I just checked this with my head of healthcare this afternoon. It will be dependent on the advice given by the Public Health England Health Protection team. So it's our duty to be reporting our numbers every day from each prison, and then the advice of when to swab and when not to swab will be given by the Public Health England team. So that's the sort of nuggets from me for now, if that's all right.
Okay, thank you very much, Caroline. I will get Stephen on the line.
Great, thanks.
One second, Stephen.
Sorry.
Right, you should now be live.
Great. Thanks, Megan. I'm just going to touch briefly on some of the issues that are relevant, I guess, to mental health services. Just touching on kind of the entry management within, and then the transfer from prison. So just looking at the entry into prison and reception, I guess there's been a reduction in receptions into prison since the block on prisoner movement at the end of March, and I think that drop has been about by 2,500 people. I mean, much of the challenge at reception in terms of the mental health side of things has been around the reduction in face-to-face assessments. So mental health screening and full mental health assessments, trying to do those or accomplish those on a reverse cohorting unit obviously needs a little bit more logistical consideration in terms of minimizing the spread of risk of spread of infection, and also some workforce planning, because I guess those environments are areas of slightly increased risk in comparison to the rest of the prison. In addition to that, gathering collateral information about new arrivals in prison can be more challenging at the moment, given the pressures that community teams have been under, and it's been really important to try and kind of establish good links with community services to overcome that. And if we can move to slide 2, Megan. This is just looking a little bit about caseload management within prison. Again, many of the challenges are particularly related to face-to-face contact. I mean, group sessions, outpatient clinics have all been stopped. There's very restricted prisoner movement within jails. Different teams will have taken different approaches to caseload management, dictated at least in part by local prison regimes and also environmental factors. For example, using telephone welfare checks on the general population within prison, given the kind of extreme situation that we're in at the moment. And also moving towards telephone appointments for the people who are more stable on caseload, and reserving face-to-face consultations for those who are acutely unwell or in crisis. There's also difficulty in monitoring patients because of the reduction in face-to-face time. So that needs to be borne in mind when we're considering making significant medication changes or rationalizing medication of new arrivals in line with kind of safer prescribing and custody guidance. I mean, locally, we've seen some confidentiality issues thrown up around this, because the telephones that connect to the prisoners' cells, where I work, are located within the prison officers' offices, and also some prisoners remain in shared cells. So there's kind of issues to work around there, which have been quite challenging. In terms of face-to-face meetings, adequately sized rooms are obviously imperative in terms of maintaining social distancing. And given that the prison estate varies enormously in terms of the built environment, that can be really quite challenging, and I'm assuming is not always achievable. The move towards expanding IP medication also requires quite a lot of multidisciplinary working, and that's primarily around risk management, looking at overdose risk, particularly given the the potential for instability and deterioration in people's mental state during this time of kind of increased restriction and lockdown. Trading medication obviously continues despite the smaller cohorts of patients and inmates that are allowed out of their cells at any one time, and it seems that the kind of use of spice hasn't been impacted massively, certainly from my experience. I mean, it's worth mentioning as well that in terms of the small number of people who are prescribed clozapine within prison, there's obviously the possibility to extend the period between blood tests beyond the usual in accordance with the current guidance, which just reduces face-to-face contact a little bit as well. I'm not going to spend too much time on the next point because I think it would constitute a webinar in its own right, and it probably has done already. But it's just looking or touching very briefly on the impact that the restrictions that we've seen have had in terms of people's mental well-being. So social distancing was enabled across the estate by the new instruction by HMPPS on the end of March, which led to the implementation of the restricted regime. So that stopped all social visits, education, training, and employment activities, as well as kind of access to gyms and religious association and so forth. Following the recent inspections by HMIP, the Chief Inspector of Prisons had noted that in the kind of vast majority of people across the 3 prisons that they were looking at, they were only really getting out for about half an hour a day at the moment. And I'm aware that, touching on what Caroline said, I guess, that Public Health England have suggested that some form of restriction, probably in terms of shielding units, I guess, primarily could be dragging on for quite some time, possibly even into the next year. But nonetheless, obviously, there's a lot of discussion and concern now about how purposeful and rehabilitative activity can be safely resumed at the current time. And there's ample evidence in the literature about the negative impacts of confinement on individuals' mental health. And as we're all aware, the prison population is a very vulnerable one, both in terms of, people with mental health conditions as diagnosed in the ICD-10, but also I think it's important to highlight this kind of sub-threshold burden of mental health difficulties that people experience in terms of managing emotional regulation and the consequences of historical trauma. So it's a very vulnerable group. I mean, at a local level, we've seen increasing difficulties that people have had in terms of managing ADHD symptoms and OCD symptoms, as well as increased referrals for kind of anxiety disorders generally and mood disorders. Looking nationally in terms of self-harm and self-inflicted deaths, as far as I'm aware, there's been 16 self-inflicted deaths during the lockdown period across the prison population. And I guess over time, we'll see if that kind of represents a spike in terms of the background figures. From the HMIP report of the kind of short scrutiny visits over 3 prisons that came out a few weeks ago, they found that recorded incidents of self-harm in those prisons hadn't risen and had seemed to have had actually dropped a little bit. And in terms of local experience, in the prison that I work in, again, there's not really been a change in terms of the number of people going on an act. And if anything, the number of self-harm incidents day by day has probably drifted down a little, but probably not by a significant amount. But it certainly hasn't spiked at the moment. I guess in terms of further complications related to the cohort of patients within the prison at any given time, it's just around a thought about the potential difficulty of those who are more acutely unwell, for example, those who are psychotic, trying to work with them in following hand hygiene guidance and social distancing guidance, because that can be quite challenging. And I guess that leads on to the next slide, if that's all right, Megan, which is really around referral and transfer to hospital. Now, each year there's approximately 1,000 prisoners and detainees that are transferred out to mental health inpatient settings, and about 300 who are remitted back to prison settings. So that's about 83 leaving prison a month and about 25 coming back. Now, the current guidance highlights that the referral, assessment and transfer process should continue as normal, but it acknowledges that there will be some inevitable delays. The use of digital technology is encouraged in terms of undertaking assessments and having clinical discussions. But there are several potential bottlenecks and breakpoints that are kind of vulnerable within that pathway. And again, if we could move on to the next slide. In terms of referral, that's obviously adequate and obviously dependent on an adequate mental health team in terms of staffing availability within the prison at any one time. Where the staffing is reduced, it can obviously impact in terms of referrals being made, and there has to be, or there should be, kind of dialogue between a prison and the services that they're frequently referring to, just to kind of establish contingency plans in that regard. In terms of assessments, again, the guidance indicates that where there are restrictions on face-to-face contact or capacity issues, then clinical discussions and assessments should be taking place using digital technology like video conferencing. If that's not possible, then telephone assessments can be a fallback position, but the assessments should be taking place. I mean, the guidance stresses that mental health inpatient services, in-reach services and prisons must ensure that they have appropriate technology, governance, policies and procedures in place to support the use of digital technology. And that's all well and good on paper, but in reality, I mean, these services are not that adept in terms of rapid change and innovation, and it can be quite challenging. I mean, for example, I should imagine that trying to expand digital communications technology in the long-term and high-secure estate is not an easy thing to achieve quickly, especially if, as a mental health team, you're kind of lobbying for that as an external partner to the prison. And whilst bridging software has been quite helpful in allowing clinicians to access video link from outside of court settings, there's quite a lot of competition for that in terms of, obviously, the courts increasingly now, medical legal experts and solicitors. In terms of face-to-face assessments, where that's required, then obviously the PPP should be worn in accordance with the guidance. Locally, I guess over the past 2 months, we've had a mixture of face-to-face video link and telephone assessments that have happened. anecdotally from other prisons, I believe that generally hospital teams tend to be requesting video link assessments, but not all prisons yet have that capability, so there have been some delays in that regard. In terms of transfer, the Emergency Coronavirus Act from the end of March contains a number of provisions that, if they were enacted, would make changes to the Mental Health Act. In terms of Section 47 and 48 of the Mental Health Act, the most significant one there is that only the recommendation from one registered medical practitioner would be required rather than two, in terms of the Secretary of State transferring a patient. That would be on the basis of two recommendations being either impractical or causing a significant delay. The potential changes also remove existing time limits for those recommendations. Obviously, those changes haven't come into play, but they remain kind of in the background and as a future possibility. There's a form that would need to be completed to kind of give justification for only one recommendation being made in those circumstances. So additional recommendations that have been made kind of out with that include that consideration should be given to the distance between the prison and the hospital that's being referred to. So it suggested that some patients could be transferred to inpatient services that are closer to the prison, but might be outside of the normal catchment area. I'm not aware of that actually happening, but presumably it's something that would be a little bit easier if it was involving kind of the larger London consortiums. In terms of the new prison procedures, there are a few things that have been put in place that could delay transfer. Those really are that given routine transfers from prison have been stopped since the end of March, permissions now needed from the HMPPS Gold Command. So once a warrant comes through from the MOJ, the governor of a prison needs to alert Silver Command, and then they need to make a specific request from the Gold Command in terms of transferring a patient or a prisoner to a hospital setting. So the kind of addition of those steps is going to lead to a bit of an increase in time. Again, anecdotally, my understanding is that hospital transfers have been delayed, and as far as I'm aware, a lot of that is due to either hospital wards being closed to admissions or hospitals trying to limit the number of admissions that are coming in at any one time. Also, there doesn't seem to be a kind of cross-trust consensus in terms of COVID testing for patients who are due to be transferred, and that's led to a number of delays over the past couple of months. In terms of remission to prison, it's pretty similar issues really, mostly around the increased kind of bureaucracy in terms of having to go through the stages through Silver and up to Gold Command before getting permission to transfer somebody back to the prison estate. 117 meetings obviously still need to happen, but they need to happen digitally where possible. If you could move on to the last slide, Megan, that's just touching on release from prison. Again, these issues are kind of shared across the services and specialities, really, so I won't kind of linger on them too long. Obviously, there's going to be challenges with regard to transfer of care. Community services are going to have to use remote methods of communication in terms of liaising with clinical teams, and as far as I understand, that's been relatively successful so far. Meeting with patients prior to discharge is a little bit more challenging, and even when they get into the community, obviously with the reduction in face-to-face contact, it's not as easy as it usually is. Community services are under a significant amount of pressure at the moment, given the kind of outflow of patients from inpatient hospital units, and also the potential kind of staffing reductions due to illness and the reduction in face-to-face contact. So it's important to recognise that and try and plan for kind of transfer of care in prison when prisoners are being released into the community in good time. And then finally, the move to providing up to 28 days of TTOs as people are being released from prison just requires that additional bit of risk assessment in terms of the self-harm and suicide potential with regard to overdose. So that's pretty much all from me. So I'll kind of hand back to Megan at that point, but thanks.
Thank you, Stephen. Shall I go through a couple of the questions quickly now before we move on to Jake? So Caroline, if you wanted to pitch in here as well. 1 second. So the first one is, can liaison and diversion assessments be added to summary care records for individuals who may end up in prison estates, as this would really help to make informed decisions on any relevant care needs in relation to both physical or mental health?
That is a really good question, and I would like to defer to Jake, as he is the HJIS clinical lead, if that's all right.
Thank you. Are you able to hear me okay?
Yeah.
Yeah, so the HJIS, or Health and Justice Information System, is the reprocurement of System 1. Summary care record, as Caroline was speaking about earlier, is an upload that comes from GP practices. Summary care record with additional information, or SCRA as it was named earlier, is basically medication with allergies that is the summary care record. Additional information includes diagnoses and other elements of the patient record, but that's only uploaded by the GP practice. There are no other environments that have the facility to upload data to the summary care record at this stage. When we move to GMS registration for prisoners this year or next year, then we will have ability to do that, but I'm not aware that liaison and diversion services are in scope for being able to upload information to summary care record at this stage.
Okay, thank you. Is there telephone contact for those without in-cell telephony?
So I think the answer is different prisons are making different arrangements, so there will be local differences. That it is possible to arrange for a room on a wing where a prisoner can be taken if you're going to take them, if you're going to give a telephone consultation from one of the in-house team. Certainly also it can be possible to arrange telephone consultations, and it's being set up to arrange video consultations, but at the moment for telephone consultations it is possible to bring somebody over to have a telephone consultation with secondary care, so with the hospital service. But for that, it is important, and it's a necessity from NHS England's side, that there is a member of the healthcare team present with the patient. So although it is ideal to have telephones in cells, as Stephen mentioned, there's partly the problem that if you're sharing a cell, then confidentiality is an issue. It is also extremely important that the prison is aware that telephone calls to healthcare should not be recorded. They shouldn't be listened to, but they shouldn't be recorded either. So that there is that, but it is possible to use wing phones, or to create a room on a wing and put a telephone in there for somebody to have a consultation with either a member of the primary healthcare team who is either working off site, or to protect them from face-to-face contact.
Okay, I'll just do one more question. Which digital tech or app are you using to do the assessments for hospital transfers?
I mean, locally within the prison that I work, it's just been the video link software that's normally been used in terms of accessing courts, and certainly the clinicians in those situations have had to go to a court because they haven't been able to access the kind of video bridging software. So it's been limited to the provisions that were already in place. My understanding is that and Jake, again, you might know a little bit more than this because it was in a document I think that you'd been part of writing, that I'd seen it, but I think there are a number of systems that were being looked at in terms of accessing kind of video linking software between kind of NHS services and prison services. but certainly where I work, nothing's been kind of rolled out. I think it does again vary from prison to prison.
Okay, thank you, Stephen. I might put Jake on now and send him live, just so you're kind of connected with your slides for the next bit, if you wanted to answer that question at all, Jake.
So there is a telemedicine rollout, and as I understand it, Visionable is the solution that's going to be procured for prisons. I don't think the kit's actually deployed anywhere at the moment, but I don't think it's far away. Happy to be contacted outside of this to put you in touch with people who can answer those questions more directly about telemedicine in prisons.
Okay then, so thank you, Stephen. Jake, would you like to continue with your presentation?
So thank you, everybody, and good afternoon, and thank you to my two previous co-speakers and Megan for asking me to come along and do this presentation this afternoon on this lovely day. So I'm going to speak briefly about preparing for release from prison, and if I could have the next slide, please. As it says there, I'm the chair of the Royal College of GP Secure Environments Group, and has already touched on the clinical lead for the Health and Justice Information System. Just by way of an introduction, it doesn't really need to go into this in any detail, but the response to the pandemic in prisons is aiming to be equivalent to those measures that are put in place in the community, but of course they can't be identical or the same. And I think we'd all recognize, for those of us who work in prisons, recognise just exactly how difficult that can be in terms of social distancing measures and trying to work around the regime. And just to say, I mean, I think we would all recognise that takes particularly careful collaboration, as has been outlined by both the previous speakers. You need to really think carefully about how that's done. So that then obviously sets up how we think about preparing somebody for release. If I could have the next slide, please. So I thought it might be useful to start with the prisoner, the patient, our client. We've spent a lot of time and energy informing our patients about what was happening from the perspective of the world outside and to what was happening to them inside in terms of the regime. So conveying that message has also had to follow in terms of preparing them for release, which is, you know, if you're going out into a world that perhaps looks very different in terms of social distancing measures that you might not be prepared for. And I'll touch on this later, but think about which part of the prison they may be coming from, if they're a shielded patient or coming from the reverse cohort unit, or from protective isolation with suspected symptoms. So again, there's a collaborative effort that's required to prepare somebody to be released from between the prison and the healthcare staff to organise that. Next slide, please. So you'll all recognise, hopefully, version 2 of the cohorting guidance, which sets out the 3 different potential units that you might use or might be versed in using in the prison setting. Does go into a little bit more detail in version 2 around householding and regime cohorts, which does complicate matters slightly, but actually the essence is the same, that if you're preparing somebody for release from a shielding unit, then having that in mind when thinking about what environment they might be going to and how to try and hand over some level of care is you know, obvious in terms of wanting to avoid them being exposed to COVID-19 as much as reasonably possible. In terms of those going from a reverse cohorting unit, if they're released from court video link, etc., then you know you're in that period of 14 days. Presents a further challenge as to what advice you might give about how they conduct themselves when they're outside and what you might advise them. So we printed off letters that explained what they should do if they had symptoms. They should go home and isolate with their family, and they should stay isolated together for 14 days. And as Caroline touched on, we haven't yet got the advice about what to do with shielding as that's lifted in the wider environment, in the wider community. Next slide, please. So, as has been described, we've obviously adopted quite a range of different ways of new working to ensure acute needs were being met. Obviously, many processes are put in place to try and detect and isolate potential cases of COVID-19, and as I've described with the reverse cohorting unit, to locate them in one particular area. And as touched on, shielding of our vulnerable patients and vulnerable groups and high-risk groups. Next slide, please. Along with the advice about cohorting, we have had some advice about how to manage our medicines, and that's already been explained in detail. So I'm not going to go through that in detail, but I have put the QR code there for you if you want to use that to find the document that's referenced there. Next slide, please. So again, I don't need to go through this in great detail because it's already been touched on, but thinking about the fact that perhaps a great deal of people were given in possession medication, or there may have been work to increase the number of people on in possession medication and minimize the number of people on not in possession medication, alongside appropriate risk assessments for that. Having to think about how those patients are then going back out into the community, hopefully will follow through in terms of those risk assessments. Bearing in mind those people that are on supervised consumption, night medications, and thinking about how we deal with vaccinations, and as we move back into recovery mode and restoration, how we go back to restoring some of those clinics, such as the vaccination clinics, and yeah, unlocking some of the restrictions we may have put in place around medication. Next slide, please. So again, there's just another link there for you to find the document there that will take you through to the guidance for healthcare teams on the release of adult patients. So that's another useful document that you may find useful. Okay, next slide, please. So much of this is already covered in Caroline's fantastic resource. Again, I've given the QR code here. I'm not going to go through it in detail because it's been touched on already. And next slide, please. So thinking about preparation for release, I've touched on most of this already. Those of you who are in a prison where there will have been patients that were identified for end of custody temporary release will recognise that not as many were released as one had hoped. As I've touched on already, thinking about how shielded patients should travel and move to their location when they leave from their shielded unit into the community is presenting a significant challenge. And I'm looking forward to the guidance that tells us how things will change in terms of unlocking the shielding for patients in the community, because that might make things a little bit more straightforward. I am going to suggest, if you're not already using it, that the release planning template or discharge seat template, secure environments assessment template, is used to help identify where a patient is registered, because that will also help you with the handover of care if there's something significant or important that you want to relay. So next slide, please. So this is the seat template. As you can see, there's a number of tabs on there. This is just a screenshot from that, which outlines a number of things, but you can see in this test patient there would be GP details available in there. I do hope that you have access to these on your version of System 1. If not, then by all means get in touch with me afterwards and I can hopefully point you in the direction of that. And the same applies with regards to the summary care record with additional information, or SCRA, as was touched on earlier. And next slide, please. So those people who have been given 28 days of medication in possession, sort of deemed the lowest risk in prison, there's probably no hesitation for most of those people being given their statins or their blood pressure pills on release in a 28-day supply in order to try and facilitate them moving back out into the community, bearing in mind the restrictions around accessing general practice in the wider community. And so as much of the in-possession medication we've been able to relay over into 28-day supply on release, we've tried to do that where possible. And of course that says that's suitable except for controlled drugs, which we are limited to 14 days. I think warning people about the fact that there are restrictions around access to the community pharmacies and the queues and the need for social distancing and accessing their medication when they have run out, and preparing them for the time taken to get that medication is really key, and is part of the messaging that I referred to earlier. Using FP10s and FP10 MDAs where possible to try and bridge that gap where perhaps you don't have that particular medication in sufficient supply to give to the individual, and has been touched on earlier, you know, relaying as much information as possible over to the substance misuse services about the supply of that bridging script or whatever medication you may have given, or you know, clinical care that you've given that's relevant to that patient, is particularly key, because of course they are sitting outside of the normal primary care avenues. Next slide, please. So I think I'd be thoughtful, and I'd be interested to hear views from people generally, but I think so much of COVID has leaned us towards thinking about how we do things differently. Two questions I would have, you know, what are the lessons we've learned, in particular around some of the things that have been touched on earlier in terms of potentially seeing reduced self-harm and other possible benefits. I'm not sure I would go that far at this stage, but what are the lessons learned, and how can it change? How can it alter how we think about our patient group? And what are those alterations that we've made would we like to continue in our current practice? Certainly thinking about the telemedicine and the telephone use and some of those other more practical considerations that are being used and adopted widely in the community. I'd like to see those deployed much more in the prison setting, because I think it just helps with continuity of care. Next slide, please. So I've got 2 out of the 3 or 4 links there, but as I say, I've given you the QR codes, and if the presentations being published on the website, then you'll be able to access those in that way. And I think that's my last slide. Thank you very much.
Brilliant, thank you very much, Jake. If you just bear with me 1 second, I will get Anna and her slides up too. Wait 1 second. Oh, why has it not put you in there with it? There we go, Anna, you should be live now.
Thank you very much. Thanks, Jake. Thanks, Megan. And a quick thank you to the SMMGP for asking me to contribute to this final element of the presentation today. I'm just going to have 3 slides to run you through some of the community elements about how we're looking after patients as they come out of prison and transition into the community. I'm mindful of time, so I'm just going to pull out a few critical points that might not have already been covered. So the first thing to say is there's no area of community practice that hasn't been dramatically impacted by the COVID-19 pandemic. You know, our services are essentially, the buildings are closed, but services are open, and we're trying to deliver urgent and essential services without compromising social distancing and isolation rules. So the big question has become, you know, what's essential? One-to-ones, group work, assessment, particularly as we're coming to that 3-month point now. Things like our long-term condition checks in primary care are becoming much more urgent. There's nearly 3 months worth of people's long-term condition care we're missing out on. And in substance misuse services, some of that biggest value that we offer is in our psychosocial interventions and our one-to-one and group work. And often that's been limited or on hold and not available. So it's been a really big challenge for us moving to this telephone and video consulting model. That's been touched on a fair amount, so let me just move on to talk about diagnosing COVID. Apologies that these bullet points have got a little bit jumbled up here. So, but the actual diagnosis of COVID in the community has been really challenging. I'm not sure how aware people are, but essentially we've been doing this by phone. Until very recent days, we've had no testing available in the community until somebody is admitted to hospital. So we've been basing our diagnosis on essential symptoms and being really mindful that we mustn't miss other critical diagnosis. We've had 2 examples in our surgery where we've brought somebody in who over the phone sounded like it was COVID, but on actual assessment it's turned out to be acute alcohol withdrawal. That's just reminded us kind of several times that not all things are COVID in these months, and we need to be mindful of serious other diagnosis and not missing them. We've seen a really interesting pattern of people both over-presenting and under-presenting with COVID symptoms. And this has been, what we've seen is an unexpected number of people potentially over-presenting with symptoms, saying they've got COVID, potentially self-diagnosed. And as that story unravels, it becomes apparent that there's some other secondary gain for them. So a phone call that says, I've got COVID symptoms, I've got to self-isolate, I need to have an in-possession methadone or increased medication. So our clinicians are having to be watchful for that type of presentation. And then the flip side, under-presenting. Often our service users are have long-term conditions and generally poor health, and they're used to waking up many days feeling horrible in the morning, and they're perhaps not recognising therefore the symptoms of a new viral infection that might be COVID, and therefore just continuing about their kind of daily routines. And within that, there's another sub-cohort who really don't want to be recognised as having COVID because it might jeopardise their accommodation or their relationships, and so they're under-presenting. And thirdly, delivering these social distancing and self-isolating messages that we've all been talking about is really difficult, a big ask in a homeless population or a very vulnerable group. We've got everybody in, following national guidance. Lots of homeless, in most cities, there's been a strategy to get everybody in to multi-occupancy hotels and hostels. That's a really positive step, and lots of new opportunities there for people, for prison leavers who'd otherwise be NFA. But we now have new multiple occupancy hotels and hostels with really variable degrees of cohorting, where infection can therefore spread quite quickly amongst those communities if we're not careful. And we're just beginning to hear about the other risks in those settings around exploitation of vulnerable groups, around debt and money lending and violence within those settings. So we've got some new challenges ahead. Can I have the next slide, please, Megan? Thank you. So how can we prepare our prison leavers best for this kind of new community environment? We need to aim for stability in those final days and weeks. If we know when people are going out, aiming to get people onto stable therapeutic doses of opiate substitute treatment, whatever is available in your setting, is vital. Confirming their address and telephone contact details for that telemedicine, and passing those on to the community teams. There's no use us holding that information if it's not reaching the services in the community that are going to be supporting patients. Our overdose advice and naloxone is more important than ever. Thinking about the substance misuse environment, the heroin quality that's out there is diminished as the supply chains are interrupted. Cost of heroin has gone up, and purity. So people are moving to new dealers and cheaper arrangements and taking much greater risks around their substance misuse. And with the additional methadone that's circulating in possession, the risk of overdose from methadone is also very high. So overdose advice and naloxone more than ever, please, before people are released. We need to be giving people real advice about COVID infection transmission in their lives. So in substance misuse, the context of how infection might be passed if you're in close proximity or using with somebody else. And this advice on social distancing, this group may well have been in lockdown may well have been in prison since lockdown started, and we just need to catch them up on what's expected and what's necessary out in the community. As Jake said, queues for chemists, queues for food, all of these things are normal to us now, but some of our groups who are just leaving prison will have not seen that yet, except on the news. And final slide, please, Megan. And so thinking about all patients on release, we've all stressed the importance of pre-release GP registration. It is vital in all times, but at the moment where our surgery buildings are mostly closed, it's really hard for new patients to get registered. Practices are registering by phone, but those new patient checks and assessments aren't happening very easily, or they're happening over the phone. So new scripts and new relationships are hard to form. So anything we can do about pre-release registration is a massive step forward. And communication remains the biggest challenge. Communication with community teams prior to release. Everything that might have changed for that person during their time with you, the new diagnosis, what meds have you given on release? And what we're finding, and I'm sure you're seeing, is that things like traditional discharge letters that get sent with the patient as they leave the establishment, the chances of them arriving in one piece are really slim, particularly if they hold an unwanted message, perhaps, that something we've changed in custody. So what we're trying to do locally is get those letters out right at the beginning of somebody's episode of care. For example, when you've done a meds rec or you've made other critical changes, don't wait for the patient to be ready for release. They might get an early release, for example. So let's get that information out to GPs in a timely fashion, either by email or post, but ahead of time. Consider a phone call and inviting your GPs to your complex patient meetings so that the continuity of care is really established. And when we're doing that, we're often making a different recommendation about prescribing to the prescribing package the patient might have arrived on. So it's useful to try and attach some of the RCGP fact sheets to that discharge letter to give our community prescribers the information that they need to prescribe safely. Moving on. And that's it really. So just remembering that our community colleagues are working with reduced opening, they're relying on telephones and videos, and we have to make it as easy for them as we can to have accurate information on release so they can provide safe continuity of care. Thank you.
Brilliant, thank you very much, Anna. I'll just have a couple of questions with the last few minutes that we have left, if that's okay. So anyone please pitch in if you would like to answer. So the first question is, where someone is released and is diagnosed with COVID, how is that information passed back into the prison to protect and help track and trace?
So in a GP perspective, if it's helpful to answer, I'm not aware of a process yet whereby that would happen. We would be relying on PHE to help us with that through their cells to feed the information back to the prisons.
Okay, thank you. What role is there for probation services, both in custody, through the gate and in the community, in managing the release process?
I think it would be great if they were more involved, wouldn't it, Megan? I think this question, speaks to the issues we have around homelessness and secure accommodation and arrangements for people on release. But I don't know if anybody else has a more positive experience, but we're struggling to make this element of the transition of care work effectively.
Okay, thank you, Anna. Many people leave prison without being registered with a GP. What processes are there in place for them?
Well, I can speak briefly to this. There should be pre-registration clinics going on, and the seat template that I showed a screenshot of earlier in my presentation is part of that work. I know when I last looked, it was probably about 40 or 50 prisons or so that were doing pre-release clinics. And that's really part of the work of the Health and Justice Information System in order to prepare people who are eventually going to be GMS registered when they come into prison, to make sure that benefit is not lost when they go back out into the community. But it's not intended for this purpose, but hopefully some of those links will be there. But if it's an area that you've identified as being a topic that you want to explore more, then there may be some work that can be done with the with NEL CSU that can help you with organising pre-release clinics and the use of the seat template, the discharge seat template.
Brilliant, thank you very much, Jake. I'll just end on some positive comments, just to say that lots of our attendees have really enjoyed today's session, and thank you for all of your helpful information. And thank you also from me to all of our speakers, Caroline, Stephen, Jake and Anna. I think you'll agree it's been a really information-packed session, and we've had lots and lots of helpful advice, and thank you for those QR codes as well, Jake. That's really helpful and something I might steal for future presentations that we do. As I said before, the recording will be available online in the next day or so. Sorry if we didn't get through all of your questions, but we'll try and get some responses back to you in some way. And do keep an eye out for future sessions that we'll be running. You can see some information on the slide there about how to keep connected with us. And I hope you enjoy the rest of your day. Thank you very much.
Thanks, bye.
Thank you, bye-bye.